was this a cardiac arrest, and leave that as a no, you're just submitting false documentation. I don't know how else to relay the gravity of the need for proper documentation. We have multiple people doing QI that keep coming back to us saying, why can't people document this? It's in the chart, it's so easy to do. And then I tell them, I don't know, because we feel like broken records from our end of this is what needs to happen. You're clicking submit and sign, attesting to the accuracy of the documentation, and then there's a lie in there that it's not a cardiac arrest. So please, please, please ensure that you have accurate documentation. It helps us make some decisions on the back end when we have complete documentation as opposed to dedicating resources just to pulling charts to correct mistakes that were placed in the charts. What else? Was there, where'd Jen go? Was it what? RAS score and what's the other one? LAMP score. Both of those need to be documented, and they are scores in the
same place as you go for if your GCS, stuff like that, or like for your P's, if you say scores off as well.
What she said. So RAS scores before and after sedation with Versed or ketamine or etomidate. So etomidate for airway management, Versed and ketamine for whatever, or for any agitation. And the ketamine would be on the airway side as well. So the RAS scores need to be documented, and then if you have a positive Cincinnati stroke screening score, then you need to roll that into a LAM score, LA Motor Score, and that will help tell you who should not go to this hospital and go to DePaul this hospital or St. Mary's, but only go to DePaul, Barnes, or Mercy because they're the level 1 stroke centers, assuming that you have a no more than a 20 extra minute drive. So that's the diversion for strokes. And with that, I will turn it over to John and John. Which were you going to talk?
Thanks, Todd. Everybody, hello. Thanks for coming. My name is John Kramer. I'm a clinical educator for Teleflex, which means I just go around and I teach this IO, and I try to just go over the stuff that you guys already know in medical school and maybe a few things that you guys didn't learn in medical school. Things are always changing. We found out more stuff and changing the way we do some things. This is John Dunker over here. He's a sales rep for the area for Teleflex. He's the one that tells me where to go and when to teach this stuff. Do you have anything you need to say? No. So, like I said, my name is John Kramer. I'm a paramedic fireman. I've been a paramedic for about 10 years now, fireman for about 8 before that. I was a medic in the Army. I've had a lot of experience with IO, and that is my full-time job. I use this stuff regularly. I just come out to clinically to do clinical education and teach this stuff. So I do have, if you guys have questions and stuff like that, I do have some background in this. I understand most of you guys are probably getting off, some of you guys are getting on, so I'll try to keep this engaged. This is very informal. If you guys have questions, stop me. If you guys don't understand something, please stop me. I just want to go over and kind of maybe do a better job than they did when they explained this to you in medic school. Everybody here, paramedics, EMTs, anybody that isn't in those two categories? Paramedics or EMTs? No? Okay. All right. Well, this PowerPoint is brand new as of Friday, and I've looked at it twice, so I'm going to do my best, but I'm going to go along with it. I might not read off of it too much, though. So today we're just going to talk about why you can use IOs. The things that we thought we used IOs on are codes. That's it, right? The life or death, this is it, last resort. We're trying to kind of change the mindset about when we're using IOs. These can be used on anybody at any time for any reason. So we're going to talk about when we use IO. We're going to talk about the contraindications for IO. There's a handful of contraindications when you can't. We're going to talk about the positions for IO, the different places that we can actually place an IO. We're going to talk about the care for IO. We're going to talk about the needle set selections and why we use them. And we're going to talk about a little bit about anatomy. And then we're going to hopefully do some hands-on. So the indications for IO, anybody that needs vascular access that you can't gain quickly with an IV is a good candidate for IO. They have done thousands of studies. There's a lot of money invested in this kind of stuff, and they found that even in the hospital setting, anytime that they're having a difficult vascular access issue, and they might even call in some specialist or the best guy there, they're taking up to 16 minutes to get an IV, when an IO has a 99% success rate. And a 97% success rate in adults and a 99% success rate in pediatrics. So indications for an IO, anybody. There is nothing you can give IV that you can't give IO, with the exception of chemotherapy, chemo agents. All right, and of course, nothing I say supersedes what your medical protocol says. So anything else can be given IO. You can use the IO for almost anything, or for virtually anything. And there's only a handful of contraindications. The contraindications for an IO are a possible fracture in that site. If you think they might have a fracture, if it's a car accident, and you think they might have fractured their arm, don't use that site. The entire bone if the bone is fractured down here, you can't use the top of it. It's just like a vein, right? It'll infiltrate somewhere. Okay, so possible fracture. If you go to find that site and you see surgical marks and they might have pins, needles, prosthesis, we're not going to use that site. The reasons are pretty obvious there, right? Just like an IV, you wouldn't start an IV through a big red swollen arm, would you? Because the possibility of infection is pretty high. You're not going to do the same thing with IO. You're not going to start an IO through an infection or a possible infection. The inability to landmark is a good contraindication for an IO. Just like an IV, you don't stick it in where you think it should be and go fishing, or at least you're probably not supposed to. If you can't landmark the site, don't go there for the IO. And the very last indication, which is probably one of the most unknown ones, is prior IO access in the last 48 hours. The reason this is really important is because we kind of need to change our mindset about how big of a deal it is to start an IO. Most of us probably think like tubing somebody, right? You drop a tube in somebody, you just bought them a room in the ICU. They're going to the ICU, right? That's for sure. With an IO, you can take them up to the hospital, find out they're faking, take that IO out, they can walk out the door before you're done with your paperwork. It's not a big deal. Go ahead, sir.
You find out that's faking sooner than going to the hospital?
It depends on whether you push fluids or not with that IO, but we'll get to that part definitely. The point, though, is that these IOs are not a life-changing thing. You start an IO, you can take it right back out, it's fine. 48 hours later, you can use that same arm or that same bone and start another IO. That's the turnaround time, okay? So we need to change our mindset a little bit on that. Difficult vascular access algorithm. I mean, really, the only thing, the most important thing about this is we need to stop wasting time with IVs. If we're going for an IV and we can't get it in the first try or two, depending on your medical protocols, I know where I work, my medical protocols are 2 IV attempts and then IO, okay? Site selection. The reason we're using IOs, the reason we pick the sites that we have are because we're using the ends of long bones. We're using them like long, large, non-collapsible veins that are always going to be there. Everybody understands how the bone marrow works, the exchange, and the most important part between the Volkmann canal is the subclavian vein on the proximal humerus. This is a big, large vein that's going to help you get access to the central circulation very, very quickly. So we're using the ends of long bones because they're large veins. We have, on average, the adult patient has got a outer bone cortex of 3 millimeters or less. So I've got these bone blocks here, and to put it in perspective, we have their outer tissue, right, their muscle, what have you, a 3 millimeter cortex, and then this medullary space is all vein. That's all, in essence. This is all where we're going. We have plenty of room, and it's a large, it's always going to be there. The proximal humerus, and I'm going to show you a real-time video here in a second, but the proximal humerus is a site that we are pushing hard because it is far, far superior than the proximal tibia we've all been using. That's what we've all been taught when we went to medical school, whether it be 10 years ago or 30. This is what everyone was taught. The proximal humerus, they've been doing a lot of studies on this, has shown a huge advantage in comparison. When we talk about the proximal tibia, that's where most people probably do their IOs. We're talking about 1 liter an hour on average. Under pressure, everything's under pressure with an IO, right? A liter an hour. With the proximal humerus, we're looking at 5 liters an hour or greater. The main reason for this is because, as we can see, when we start our IO here in the proximal humerus, we have the subclavian vein right here. So when we show this real-time fluoroscopy, we're going to show just how quick a medication can get from an IO to the right atrium of the heart. And this is yep. All right, so there's your IO, right proximal humerus. Here's our fluid right here. Here's our injection, and here's our right atrium. It's that quick. It is that good. I want you guys to consider, while we talk about this, the proximal tibial IOs that you guys have done. When we're doing CPR, what do you think our efficiency is as far as what the cardiac output is? Anybody? Anyone want to take a guess, percentage-wise? No? Okay. About 25%. So about 25% efficiency when we're doing CPR. That's how efficient the heart is moving blood. Okay? So if we're moving blood at 25% and we're giving medications in the proximal tibia, what do you think our time frame is from getting that medication from the tibial IO to the heart? In comparison to the proximal humerus and its proximity to the heart. It's a leaps and bounds. It's a big, big difference. So the site selection. So every adult patient has got 6 sites, 1 on each side. The pediatric patient has got 2 extras. The proximal humerus, which I am encouraging you guys, hopefully if you guys leave here today, the next IO you do will be the proximal humerus. I feel pretty strongly about it, and as I mentioned at the beginning, I'm an educator, I'm not a salesman. This works, this is good. The proximal humerus, the distal femur, this is for our pediatric patients only. We're gonna go over this again as well, because I don't think a lot of people have this I don't think they teach this a lot. The proximal tibia, which is the one we all know, and most people don't know about the distal tibial site. It is a site, probably the least preferred site, but it is a site that you can use. And we're going to talk about how to landmark and find each one of these. So, site identification. We're going to start with the proximal humerus because, as I mentioned, this is the most used and best possible site. The sound on this is most likely not going to play through this system, and if it doesn't, I'm just going to talk the whole time. Yep, that's not gonna work. Okay.
You're showing me?
No, I'll just talk while they do the video here. So this doc's gonna locate the proximal humeral IO. This is all of this is the textbook answer on how he's gonna do things. The first thing he's gonna do is he's gonna feel for the humeral head, okay? He's just getting an idea of where he's going. Then he's going to take the inside aspect of his hand, first he's gonna position the patient's hand, either across the abdomen or thumb to the back. Okay, so rotating your hand like this, which is what you guys are all probably going to prefer because then you can strap it in that way. He's going to take his hands and put one right in the center. Actually, yeah. I'm sorry, guys. I haven't. So he's going to take the inside aspect of one hand and he's going to go right here in the shoulder. Now, when he takes his arm and I set it here for positioning, I either set it here or I set it here and I rotate it in. Here's what I'm doing. I'm taking I'm taking the proximal humerus, our greater tubercle, which is my insertion site, and I'm rotating it into view. Right here is what we call the bicipital groove. This is where your bicep tendon runs through and your nerves run through. So by rotating his arm in, all I'm doing is tucking that bicipital groove in and away and out of danger, and moving the tibial tuberosity into view. So then, I'm going to take this aspect of my hand, start right here. The next one, I'm going to go right where the seam is on his shirt. Then I'm going to bring my thumbs together. All this is giving me a starting point from where I'm going to start palpating. So really, I know where I'm going, but this just helps you find your spot. From there, you're going to push, palpate hard and up. You're not going to walk your fingers. If you walk your fingers, you'll miss it. And what you're feeling for, if you're feeling for the surgical neck, this is described as a golf ball on a tee, but you can feel where the bone starts to come out and form that ball, and you'll feel that little bump. Once you find that bump, you're almost there. So Once we start palpating, push hard, I find that pump right there, that centrical neck. I'm gonna go 1 to 2 centimeters above that. That's my insertion site. It's very, very easy, simple to find. When we get finished, we're gonna try to do we'll get up and we'll do some landmarking. You guys can play with these bone blocks and we'll go over some more stuff if anybody has any questions. But very simple, palpate together, find that surgical neck, 1 to 2 centimeters above that. And then, once I find that location, I'm gonna go 45 degrees from his spine and 45 degrees from his back. And I'm gonna use a 45 millimeter needle. So all 45s, all the way around. Who knows, which way do we do, what angle do we come in when we do a tibial IO? Anybody?
90 degrees.
90 degrees to the bone. Every other IO is 90 degrees to the bone. But when we do proximal humerus, we're going 45 degrees to his spine, 45 degrees to his back. And that's our insertion site. And we're always using a 45 millimeter needle. Okay? All right.
When we use the Lucas and arms are strapped like this, is that okay?
Great question. Great question. So at the end of this, we talk about these mechanical devices, but while we're talking about it, the greatest threat to any IO is movement. So even when we're talking about our tibials on our adult patients or our distal femurs on our pediatric patients, we have to secure those IOs. With the proximal humeral IO, there is only one danger, and it's this move right here. Anything that brings this arm up is going to bring that IO right up against the acromion and possibly could damage it. So the Lucas device, the auto pulse, all of those are totally acceptable as long as you're securing their hands well. So because that's this position, right, for the Lucas. So once you do that, and then they have straps for the hands, so that is totally acceptable. That there's going to be no issue there. They can do almost anything. It's just this one that we're worried about. Okay? All right, so the insertion angle, like I talked about, is going to be a 45 degrees to their spine, 45 degrees to their back, and that's your insertion site. And we're using a 45 millimeter needle. The positioning is very, very important. This is going to help you. It's going to protect the patient. It's going to protect that bicipital groove, and it's going to move everything right where you need it, so that you can start that OIO, especially when they're laying prone, or I'm sorry, supine, and you want that to be towards the top where you're kneeling. Proximal tibial site. So, most of us are familiar with this, but just in case you aren't. The proximal tibial site is found by first locating the tibial tuberosity. That is a big fancy word for the apex of this triangle, where their bone comes together. The apex of this triangle is the tibial tuberosity. Once you find that, you can palpate that on yourselves. If you guys like, you can feel it. Once you find that, we're going 2 centimeters medial. That's our insertion site. On those patients that you can't find it, if you can locate the bottom of the patella and go 3 centimeters distal of the patella, and then go 2 centimeters medial, you'll be good, okay? And it's all about feel. If you guys palpate on yourselves or feel on yourselves, you guys can grab, I don't care how big you are, you can grab your tibia and literally follow it all the way up. Once it starts flaring out, that's our insertion site, okay? And it's going to be even more helpful when we go and we find the distal one. But once it starts flaring out here, this is our insertion site. We're doing which angle to the bone? Anybody? 90? Okay. So, on the infant, this is going to be a lot more difficult to find. If you can't find the tibial tuberosity, find the bottom aspect of the patella, go 1 centimeter distal, and go 1 centimeter medial, and you'll be there, okay? Again, these are things that you can just grab between your fingers and really dig and find, okay? We know at this point, God forbid you're doing this on a child, but at this point, you're probably in some dire straits. So get in there, grab it, feel for it, and make sure that you can landmark it, because if you can't, that's a contraindication for starting an IO if you can't landmark. As we mentioned, 90 degrees to the bone. Now, while we're on this, the difference between the tibial IO and the humeral IO is pretty big. This represents a humeral, your humerus, okay? We have a lot of tissue at top. We have a 3 millimeter cortex on average, and then we have medullary space, and lots of it. This represents a tibial IO. We have our tissue, we have our cortex, we have a very, very small area of medullary space that we need to leave that tip of that needle in, and then we have the cortex on the other side. This is a very, very small window, okay? So that being said, if you're inserting an IO on this, when do you stop? Once you start drilling on this, when do you stop? Anybody? No? Okay. When you feel it, when you feel the loss of pressure. It's not like putting in a drywall screw, you don't just drive it. You're gonna start driving and you're gonna feel it get easier. That's when you stop. That's when you put that needle head right in the middle of that medullary space. Now when you do it on this, where do you stop? You don't have to, because you have all of this medullary space. So when we do our proximal humeral IOs, you can just put those down to the hub. You can put it down to the skin and you're good. When we do our proximal tibial IOs, we have to get that sweet spot. We have to get right in that medullary space, which means we're going to drive until we feel that loss of resistance, and then we're going to stop. All right, distal tibia site identification. This is again something that I would say is probably the least preferable spot, but there is a scenario that you could have to, this is all you can get to, and you got to access this, go for it. The distal tibia spot is pretty easy. It's found by finding what they call is the most prominent aspect of your medial malleolus. That's the name of your ankle. So if you find your ankle, the very top portion of that, and you move proximal 2 centimeters, that's your insertion site. Again, something you can just grab between your fingers and find that big open area where it flares out at the end, and that's your insertion site. Although the distal tibia has got a small window, the proximal tibia has got a small window, the distal tibia has got an even smaller window, okay? Keep all that stuff in mind when you're landmarking these. And as for the pediatric, you're finding the most prominent aspect of the medial malleolus and going 1 centimeter proximal to that. So 1 centimeter above that. Any questions on that? All right, the distal femur for a pediatric. God forbid you guys have to do this. The biggest thing on this, just like all IOs, is securing the leg, but specifically on this one, there is a lot of things going on in this. There's a lot of muscle, a lot of tissue. Securing the leg on this, whether they be conscious or not, is priority. Okay? Once we do that, what we're gonna do is we're gonna find the very edge of the patella, the most superior part of the patella. We're going to feel that. We're going to move 1 centimeter proximal to that, and then 1 centimeter medial to that. That's going to find us right here, and that's also, as we'll see on any of these models, it's our biggest. I'm going to pass this around. It's our biggest, flattest, most accessible area, and it's still a pretty big target area. However, your space is still going to be pretty limited, okay? You have a small medullary space to hit. So, if you want, will you pass these around for me? Just if you guys see any of these, actually, I'll just go the other way with these. Pass those around for me if you guys want to see any of these. I'll get them around. All right, any questions on that? Finding on the pediatric, on the distal femur? All right, needle set selection. I know we all probably at one point or another called them this. We have a yellow, a blue, and a pink. These are not an adult, kid, pediatric size needles. That's not how they work. They are all weight-based. They are not age-based. However, they are all the exact same gauge. They're all 15 gauge. You're not going to get a better flow rate from a yellow needle than you are a pink needle. They're all the same gauge. What we prefer to call them is the 45 millimeter needle, the 25 millimeter needle, and the 15 millimeter needle. The needle set selection is pretty key when it comes to the proximal humerus. You can always use a longer needle than you need it, but if you use too short of a needle, it will become displaced and you won't end up in the right spot. So, on these needles, they put these little black lines. This black line right here is your 5 millimeter line. Okay, that means you have 5 millimeters left. If you go to insert this needle and you can't see this 5 millimeter line before you start driving, you don't have enough needle. You're going to have to go to the next one. If you do a proximal humeral IO, you're going to use the 45 every time, no matter what. You're going to use proximal humor. Or I mean the 45 on the proximal humor. Other than that, if you, where did I put this? For you guys that have or haven't started IOs, there is definitely a wrong way to do this. When you go to start an IO on a patient, once you landmark the correct position, you're going to select what needle you think you need, attach it to the driver. It's magnetic, it's going to sit right on it. You're going to find your spot, you're going to insert it through the skin and up against the bone. If you don't do this, it will grab all of their skin, especially on your old ladies. It will twist it, it will rip it, and it will make you look really bad. And it will hurt, so don't do it. So insert all the way up against the bone before you start driving. Now, I'm all the way up against the bone, I haven't started driving yet, and I can't see that 5mm mark. If I try to insert this needle, it's going to become dislodged. It's not going to hold. However, if I grab my 45 because it's all I got, or it's the first thing, or because that's what the fireman handed me, and I go and I got way too much needle here, I can still insert this needle till I feel my loss of resistance and have it sticking out this far. That's okay, because somebody smarter than me has come up with a tegaderm securing device that's going to telescope and help hold that in place. So once we insert this, it's still going to telescope up and it's still going to hold it, and then we're going to be able to strap it down and we'll be okay. So you can always use too big of a needle. Do not use too small of a needle. Let's see. Like I said, they're all 15 gauge, keep that in mind, and none of them are MRI compatible. So that's where the next thing comes in. These little wristbands. I know that we don't use these. I know you guys don't. I know that I don't always. These wristbands come in the little kits. These are not just for the patient, they're for you. They're for that legal thing that's going to happen to you when it's a really good call and there's way too many people in that room when you try to transfer care and nobody's listening to you and an IO gets missed. Or something gets broke off and nobody even knows about it and this patient gets sent to MRI. This is to cover you from that happening. Okay? Go ahead, Doc.
So 5-ish years ago, Barnes had to settle a multi-million-dollar lawsuit for a lady getting her leg chopped off because some EMS agency brought in a cardiac arrest, and they may or may not have said in the report that they attempted an IO in one of the two legs, and so Jake Keeperman was the attending in the room, and he started an IO in that same leg. They got Ross, they resuscitated her, put her in the ICU. She got a bunch of vasopressors run through that same IO for a while, and it was extravasating out, and eventually it caused a whole necrotic wound that forced the leg to be chopped off. And they got hit with the suit because no one had put the wristband on the wrist or the ankle and made sure that the hospital was aware that an IO had been attempted. Had it been known, they would have just moved to the other leg and no one would have cared twice. But that stupid piece of paper would have saved Barnes or this hospital for this situation. Could have saved them millions of dollars that no one has just lying around. So, yeah. We can't blame City because they probably didn't have the IOs at the time.
So you guys know how this goes, right? Almost everything we're trying to protect ourselves too, okay? Obviously we're not trying to harm the patient, but we need to protect ourselves as well. That's what these are for. Every one of these little kits, every needle that you open has got one of these in there. On top of that, there's a 1-800 number in case you guys have questions. It's a 24-hour live help number. But these are here to protect you, so you know that's what these are for. They also will come with this little bone block here, or this little needle block here. These work really, really well. Please don't put any of my needles in them because then they're trashed after that. I won't be able to get them out. But when you're working your code or whatever and you're in a house and things are weird, this is a good thing to have. All right. Like I said, inserting all the way through to the bone before we start drilling. If we insert a needle to the bone and we're up against the bone and we haven't started drilling yet and we don't see that black line and we realize we don't have enough, is that count as an insertion? No? No, it doesn't. But if you pull that trigger even one time, count it as an insertion, okay? Just like that, protecting yourself. If you change your mind, you pull out, you put another IO, you grab a 45 and you start that IO and it infiltrates, and you make the patient sick, it's gonna come back on you. Insertion. I'm gonna, again, talk through this video because I don't have you won't be able to hear it. But after he landmarks and he starts his IO, you're gonna notice two things. One, it was quick. Actually, you're gonna notice a couple things. One, it was quick. Two, that 45 on the proximal humerus, he put it all the way down to the hub. And three, this guy doesn't react nearly like you'd think he would for getting something drilled into his bone. So once he finds his site, he's through the skin, he's up against his bone. You still see that 5mm mark. He drives, he's to the hub. This guy doesn't care. He unscrews it, pulls it out, and we have a good IO, okay? Then we're gonna go on with our securing device, which goes on first. This is backwards compared to what you guys, you know, an IV where you put the lock on first.
How much Dilaudid was he on?
None. I wasn't there, but none. But this is the opposite of our IVs, where we're gonna put the securing device on first, and then we're gonna put our lure lock on. That's gonna help hold everything together. And we're going to talk about, by the way, we're going to talk about the conscious patient with the IO and medicating them. Manual insertion is very doable. It's a back and forth motion. It's pretty simple. These things aren't threaded. You're not going to be able to screw them in like a drywall screw. They're not threaded. But if you guys want to try with these needles, once we get done with the PowerPoint, you guys are more than welcome to try manually inserting them on these bone blocks. Removal. So once we start IO, the IO insertion doesn't hurt. On that conscious patient, we just saw it. What is going to hurt is whether we aspirate or push anything. If we try to do that on the conscious patient, that's going to hurt. Any change in pressure in your bones are porous, but not by much. So any change in pressure is going to hurt a lot. And if you guys forget these steps and you pick up that old lady where you know you need access, you start an IO, but you don't need anything yet, you don't do it, and you start pushing a flush just because, or you don't think about it, you might make that situation if she's already having a regular heartbeat or something's going on and you make it hurt, you're gonna make it worse for yourselves and her. So with adults, once we start IO, you can try to aspirate. You might get something back, you might not. There's times that I haven't gotten anything back. But if you flush and then aspirate, you will get bone marrow back. You'll be able to tell. That being said, I don't know your, are we not even talking about drawing labs?
No.
Okay. All right. It can be done, but you guys don't do it, so we're not going to talk about drawing labs. So once we start our IO, for an adult patient, 5 to 10 mLs is recommended for the flush, a hard flush to displace all that marrow and fibrin, and then it's going to be ready to accept our fluids. Again, under pressure. Everything's under pressure. For a pediatric, 2 to 5 ml.
Aren't we